This content is AI generated for informational purposes only and should not be directly used for clinical decision-making.
Hello and welcome back to the Neurosurgery Hub podcast. I'm Dr. Eris, Senior Attending Neurosurgeon.
And I'm Dr. Alara, Research Fellow. Today, we're looking at a fascinating new study from the journal Neurosurgery titled Hydrocephalus Caused by Methylmalonic Acidemia, Clinical Characteristics, Optimal Timing of Surgical Intervention, and Health-Related Quality of Life. It's a 2026 release coming out of Peking University First Hospital.
This is a crucial topic for us, Alara, because while hydrocephalus is our bread and butter, hydrocephalus secondary to metabolic disorders, specifically methylmalonic acidemia, or MMA, is a different beast entirely. It's rare, potentially fatal, and honestly, the decision-making process for when to move from medical management to a VP shunt has always been a bit of a gray area.
Exactly. For our listeners who might need a refresher, MMA is the most common organic acidemia in China. It's a genetic metabolic disorder that leads to the accumulation of methylcitric acid. While it's primarily a systemic metabolic issue, hydrocephalus is a known complication. The paper notes an incidence rate of about 5.8% to 6.8% in the MMA population.
And when it happens, the prognosis is often poor. The authors here looked at a decade's worth of data, from June 2012 to March 2022. They identified 77 MMA-related hydrocephalus cases out of a massive cohort of over 1,600 hydrocephalus patients. That really highlights the rarity, doesn't it? Only about 4.6% of their hydrocephalus admissions were due to MMA.
It does, and they followed these patients for at least 2 years. What I found striking was the genetic profile. Clinical manifestations were most commonly associated with mutations in the MMHC gene. In fact, the C609G to A mutation was present in 70% of the cases.
Let's talk about how these kids present. We're usually seeing infants, right?
Yes. The most common clinical manifestations they identified were developmental retardation, poor appetite, and altered consciousness. But the metabolic backdrop is what complicates the neurosurgical picture. The study mentions that about 40% of these patients can actually be managed effectively with pharmacological intervention alone, specifically things like cobalamin injections and L-carnitine.
That's the medical versus surgical dilemma we face in the NICU or the pediatric ward. If we can avoid a shunt in a metabolic patient, we want to. But 66 of their 77 patients, that's over 85%, eventually required a ventriculoperitoneal shunt, or VPS. The authors really went deep into why and when that shift happens.
They used the Evans index, the ratio of the maximal width of the frontal horns to the maximum inner skull diameter, as a primary radiographic marker. They found that the VPS group had a significantly higher Evans index than the non-VPS group. Specifically, they identified an Evans index cutoff point of 0.45.
That's a useful red line for residents to keep in mind. If you're seeing an MMA patient with an Evans index north of 0.45, you're likely looking at a surgical candidate rather than a medical management candidate. But the study goes beyond just the if. It really focuses on the when. They looked at surgical revision rates, which were quite high, right?
Very high. Out of the 66 patients who received a VPS, 19 of them, nearly 25%, required revision surgery. When the researchers compared the revision group to the non-revision group, they found two critical factors: the duration of drug treatment and the age at the time of surgery.
This is the meat of the study for me. It's easy to see a big ventricle and want to rush to the OR, especially in a symptomatic infant. But what did the data show about rushing in?
It showed that patients who needed revisions had a significantly shorter duration of drug treatment and were younger when they had their first surgery. Specifically, the optimal cutoff points to reduce the risk of revision were a duration of drug treatment greater than 1 month and age at surgical treatment greater than 4.5 months.
Let's pause on that. For a resident on call, the instinct might be to shunt an MMA patient the moment the diagnosis of hydrocephalus is made. But this data suggests that if we can stabilize them metabolically with drugs for at least a month, and ideally wait until they are at least 4.5 months old, the long-term success of that shunt is much higher.
Exactly. The paper suggests that the metabolic state needs to be optimized. If you operate too early during the acute metabolic crisis, you might be setting the patient up for complications. The revision group also showed lower scores in psychosocial health and school functioning on the Peds-QL-CHAMP scales, which brings us to the health-related quality of life, or HRQLL, aspect of the study.
I'm glad they included the Peds-QL 4.0 generic core scales. We often focus on is the shunt working and is the Evans index decreasing, but we forget the social and emotional cost. What did the quality of life data tell us?
The non-VPS group, those managed only with drugs, scored better across all Peds-Squel Champ scales compared to the surgical group. That's expected given the severity of their initial presentation. However, within the surgical group, those who required revisions had significantly lower psychosocial health and school functioning scores. It suggests that the burden of multiple surgeries and complications has a lasting impact on their development and well-being.
It really drives home the point that the first surgery needs to be the only surgery if possible. To summarize their findings for the clinical team, they recommend an Evans index of 0.45 as the threshold for surgery. But even if they hit that threshold, we should try to ensure they've had at least 1 month of medical optimization and have reached 4.5 months of age.
And we can't ignore the genetics. Since MMHC mutations are so prevalent in this cohort, early genetic testing for any infant presenting with hydrocephalus and developmental retardation is vital, especially if there's any hint of a metabolic acidemia or organic acidemia.
Right. It's about the clinical profile. If we see developmental retardation and poor appetite in a hydrocephalus patient, we shouldn't just think pressure, we should think metabolic.
The study also mentioned the initial therapy they used, intramuscular or intravenous cobalamin at 1 to 10 milligrams per day, and L-carnitine at 100 to 300 milligrams per kilogram per day. This metabolic stabilization period is what allows the brain and the body to reach a state where surgical intervention becomes safer and more effective.
It's a classic example of neurosurgery intersecting with pediatrics and genetics. We aren't just plumbing technicians, we have to understand the underlying biochemistry. If the methylcitric acid levels are through the roof and the patient is in a metabolic crisis, that VP shunt is much more likely to fail or have issues.
The authors concluded that while those with severe hydrocephalus need the surgery to improve their quality of life, the timing is the pivot point. By waiting for that 1-month window of drug treatment and the 4.5-month age mark, we significantly reduce surgical complications.
This is a strong retrospective study. 77 cases is a significant number for such a rare condition. For our practicing neurosurgeons, this provides a much more evidence-based framework for counseling parents. We can tell them, yes, your child needs a shunt, but waiting a few weeks while the pediatricians stabilize the metabolic markers might actually give your child a better long-term outcome.
And it gives us a clear objective marker with the Evans index. No more, it looks a bit big. We have the 0.45 cutoff.
Excellent. Well, that's a deep dive into a very specific but vital corner of pediatric neurosurgery. Any final thoughts on the paper, Alara?
Only that it reinforces the need for a multidisciplinary approach. The best neurosurgical outcome in MMA patients clearly depends on the best medical management.
Well said. Thank you for walking us through the data. To our listeners, remember, Evans index greater than 0.45, drug treatment greater than 1 month, and age greater than 4.5 months. Those are your golden numbers for MMA-related hydrocephalus.
Thanks for tuning in to the Neurosurgery Hub podcast. We'll see you next time.
Goodbye.